السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. نبدأ هذه المناقشة about the obstetric examination. This lecture is directed to the medical students who will attend the long case examination in obstetrics. The objectives from this lecture: the student should be able to perform the obstetric examination for a pregnant lady, perform the obstetric examination for a post-operative case after cesarean section, and present their findings on a clinical assessment during exam. The prerequisites for examination: you should stand on the right side of the patient, and these should be applied for any examination. Any examination you will attend as a medical student, you should be strict for the following rules. You should be on the right side of the patient, never stand on the left side. Introduce yourself to the patient and ask for permission for examination. There should be privacy for the exam, and the exposure according to the area to be examined. For example, the chest, the upper half of the body should be exposed, the abdomen from the nipples to the mid-thigh, and the lower leg examination should be from the groin downward. Paired organ should be examined bilateral. So these rules will be applied for the whole presentation. Okay? Examination in obstetric, we have main three examinations: the general examination, the abdominal examination, and deep vein thrombosis examination is very important. When the supervisor asks you to examine the patient, you should start by general examination. You go on and you say, I will start from general examination, unless the examiner specifically concentrate on a specific examination, you will be directed towards this examination. Otherwise, you start by general examination. General examination is divided into three main schemes or parts so that you will not forget any of them. First, the general look of the patient. You describe the patient as if she is, whether she is sitting, lying. Then the mnemonic JACCOL, so that you will remember the main important things in general examination: jaundice, anemia, cyanosis and clubbing, edema, and lymphadenopathy. This mnemonic is only for memorization for you, and definitely it will not cover the all things required in general examination. The other part is the vital signs, and this is the main scheme in general examination. If I ask you what is the main or the most important thing in examination, is the vital signs, because from its name vital, these are very critical, which include the pulse rate, respiratory rate, blood pressure, and temperature. Okay, by general examination, as I said, when we start, always we start by general examination. First of all, we have the general look of the patient. We describe the patient as she is, whether she is sitting, she is lying on bed, she is breastfeeding her baby, and we describe what we see. The patient is young age, middle age, or elderly age group. Young age between 20 to 40 years old, and usually the majority of our patients in obstetric are young age group because they are productive age. Middle age between 40 to 60, and beyond 60 elderly. The level of consciousness: is the patient conscious or unconscious, or she is in disturbed consciousness? The patient is oriented in person, place, time, or not oriented? She is cooperative or not? Sitting or lying? She is irritable or comfortable? She looks ill or looks well? For example, when the patient is smiling and she is sitting, she is well. But when she is after cesarean section, she looks ill. The body build: she is obese, overweight, thin, underweight, and so on. Whether there is dyspnea and tachypnea, if the patient has difficulty breathing or breathing very rapidly. the clausma or the mast of a pregnancy, and other pigmentation, for example, ecchymosis or petechiae in any area exposed to you at time of examination. For example, the dorsum of the hand, the face, and any exposed area. Cannula should be mentioned, and if there are allergy testing or markings also obvious should be mentioned. Facial edema or puffiness, and this is especially seen in the hospital for cases with preeclampsia. We see the face is puffy, and if there are any overt deformities seen from the first look, I should mention it with the general look of the patient. Let's practice the general look on this woman. By general look, the patient is a young age pregnant woman. She is conscious, cooperative, oriented in person, time, and place. She looks well, sitting comfortably on bed. She is not dyspneic, not tachypneic. There is no clausma or pigmentation or any deformity, no cannulae. And the patient is in a comfortable position. This is the first case, as it is clear that the patient has no complaint. Okay, let's practice on the second case. My patient is a young age pregnant lady. She is conscious, oriented in time, person, and place. She is cooperative. We assume that we spoke with her. She is lying uncomfortably on bed. She looks ill, as she looks in pain. There are two monitors connected to her abdomen, one for the fetal heart. You see 141, this is the fetal heart, cardiotocography, and the other monitor for the uterine pressure. This is the tocography, measure the uterine pressure. The patient has cannula in the dorsum of her left wrist. The cannula is blue in color. The cannula connected to IV giving set, and she is receiving, that's to say, IV fluid, for example, normal saline or glucose water. The patient is not dyspneic, not tachypneic. She has no clausma and she is not puffy. And overall, the patient looks in pain, as she is in labor pain. Okay. This is what we mean by the clausma. You see, this is the mask of a pregnancy. Due to excessive melanin deposition in the face, there will be a brownish discoloration in the face. This is the clausma or the melasma. And here, this is puffiness of the face. If we see such a case with a periorbital edema, the nose, the face is swollen, this is puffiness, and this is an independent type of edema. The face and the hands, if they are swollen, this is a risky sign, especially for preeclampsia. While the legs and the lower abdomen, lower back, these are dependent edema. That is very common in a pregnancy. Okay, after we complete the general look of the patient, now we take the mnemonic JACCOL. This is for memorization for you: jaundice, anemia, cyanosis, clubbing edema, and lymphadenopathy. Usually, for a proper examination, we start from the face, then the hands, then the legs. Important note that the paired organs should be examined together, like the eyes, hands, and legs, for comparison between these two organs. Okay, we start by the face. First of all, the eyes. We examine for pallor, jaundice, hydration, infection, discharge, if there is any conjunctivitis, and redness, and so on. Okay. For jaundice, we raise the upper eyelids and ask the patient to look downward in a light sun. And here we see that there is yellowish discoloration of the sclera. We can say jaundice, but if there is no yellowish discoloration of the sclera, you cannot say there is no jaundice, because the clinical jaundice is different from biochemical jaundice. So we say here the patient is jaundiced, or if it is white sclera, you say that there is no yellowish discoloration of the sclera. Next is the pallor. With 2 fingers, 2 hands, you examine the conjunctiva bilateral. I concentrate on this bilateral, and you compare with your nail bed. If the conjunctiva is pale, you say that the conjunctiva looks pale, okay? And if the examiner asks you to examine for pallor, the pallor should be examined in 3 sites: the conjunctiva, the buccal membranes, and the palm of the hand. By comparison, you compare your hand with the patient palm, okay? And after these 3 sites, you say that the patient is pale or not, okay? Yes, the mouth examination. After the eye, the mouth examined for pallor, cyanosis, the mouth hygiene, dental care, if there are caries or not. The hydration status, is the patient is well hydrated or mildly dehydrated or severely dehydrated. If there is angular stomatitis, this usually occur in the corners of the mouth because of iron deficiency and gingivitis. Okay, this mouth examination, let's practice this case. As I see, the patient is looks normal, hygiene. The mouth is mildly dehydrated, normal skin care. The patient is not pale. There is no cyanosis, no angular stomatitis, and no gingivitis. Okay, so this looks normal apart from mild dehydration, as the skin should be glistening, okay, contain a lot of saliva. But if the tongue is dry or coated with white, this is a dehydrated mouth. What about cyanosis? We have central cyanosis, mainly the lips and the tongue, and peripheral cyanosis in the nails, okay, and the extremities. Okay. Next, after the eyes, the mouth, we go to the neck. The neck contains the transverse group. This is the submental, the submandibular, the pre-auricular in front of the ear, post-auricular, and then we have the longitudinal group along the jugular vein. Then we have the supraclavicular lymph nodes, okay? And here, as we see, we are facing the patient. We start from here, the submental group, submandibular, pre-auricular, post-auricular, and then along the jugular group. And then the last thing is the 2 supraclavicular, the right and the left, supraclavicular lymph node. After the neck, we go to the hand. We examine the hand for pallor, cyanosis, clubbing, koilonychias, palmar erythema, cannula, deformities, infection, for example, fungal infection for the nails, which is common in females because of housework, and if there is any tremor indicating a neurological problem. Here, the clubbing, normally there is an angle here between the 2 fingers. If these fingers, the angle disappears, this indicates the clubbing of the fingers. This is koilonychias, which is a sign of severe iron deficiency. And here, palmar erythema, you see all the palm is erythematous. This is one of the features of a pregnancy due to hormonal effect. It causes peripheral vasodilatation. Okay, after the hand, we go to the legs. Edema is part of general examination. You press bilateral, you see, with 2 hands over the lower third of the shin of the tibia, because this area is bone covered by skin. So we press for 15 seconds. And as I said, bilateral, and looking for any pitting edema. Other sites for examination for edema, the medial malleolus, and the dorsum of the foot. In the same way, we press bilateral for 15 seconds. And we can say that there is a bilateral oedema, or there is no oedema or mild oedema. You see this case, when you press and you remove your finger, you will see that there is a severe pitting oedema. Bilateral pitting oedema is a very common in a pregnancy, and it is seen in 80% of a pregnant women. However, you should exclude the preeclampsia, you should measure the blood pressure and send her for albumin, and you should be confirmed that this is an innocent finding of normal pregnancy. Okay, you see this lady at 6 weeks gestation, both legs look normal, and here at 36 weeks, both legs are swollen due to the effect of a gravid uterus on the pelvic veins that will impede the venous return and will cause oedema. The third part of general examination is the vital signs. This part is the main and the most important part of examination. For the vital signs, it constitutes of the pulse rate, and you should be aware that not only the rate from the radial artery, you can tell us about the volume and the rhythm. You measure the rate for 30 seconds, and if there is any abnormality, you count for 1 minute. And if you measured for 30 seconds, you will multiply by 2. So let's assume that it was 35. We multiply by 2. So we say that the pulse rate is 70 beats per minute, regular, good volume. What about the respiratory rate? You measure for 30 seconds. And while you are just still catching the wrist, you measure the respiratory rate so that you will count for another 30 seconds and then multiply by 2. What about the temperature? Usually we measure the axillary temperature and add 0.5. And the blood pressure measurement in sitting or lateral position, because the supine position will give you a wrong lower readings because of the pressure of the gravid uterus on the major vessels, so will impede the venous return and the cardiac output will also be reduced. The Korotkoff 1 is the systolic and the Korotkoff 5 is the diastolic blood pressure. What about the normal changes in a pregnancy? The pulse rate will increase normally in a pregnancy by 10%. So if the normal between 60 to 100, in a pregnancy normally it will be between 66 to 110. The respiratory rate also will be raised. If the normal between 14 to 18, here we can see up to 20, 22 is still normal in a pregnancy. The blood pressure usually reduced in early pregnancy. This is how we measure the pulse rate. You catch the hand just like shaking, okay? And with your right hand, while the left hand is applied over the radial artery against the radius, the head of the radius bone. Here we do just a gentle flexion and pronation of the hand so that the radial artery will be easily felt. We count, as I mentioned, for 30 seconds and we multiply by 2 and we gave the rate, rhythm and the volume. Here the blood pressure measurement. This is a pregnant lady. As we see that she is sitting in bed. We apply the cuff over the arm. Of course, we should choose the proper cuff. If she is very obese or very thin, we choose the proper size. We apply the cuff over the arm. 2 finger breadth above the cubital fossa. This should be slightly higher up. Then we inflate the cuff and we put our hand on the radial artery. Once the radial pulse disappears, this means we exceed the systolic blood pressure. Then, once the radial pulse disappears, we start to deflate the cuff. The deflation should be slowly, 2 to 3 millimeters per second. And we put our stethoscope over the brachial artery here. The first sound we heard is the Korotkoff 1, which is the systolic, and we go on in deflation. The final voice, cortical 5, the disappearance is considered as the diastolic blood pressure. Normal blood pressure should be 140/90 and less. Okay. The cannula examination, this is part of general examination. If we see a cannula, we can examine for, first of all, the site of the cannula. Ideal cannula site should be away from the joint because the catheter of the cannula will obscure the movement, and in non-dominant hand. The color of the cannula reflects its size. The dressing of the cannula, is it well dressed or the dressing is poor and soiled with blood? Connected fluid, you should mention what type of fluid is given to the patient, and examine for signs of thrombophlebitis. First, by inspection, we inspect for swelling and redness, features of inflammation, and by palpation, we palpate for hotness, tenderness, and cord-like vein. The gauge of the cannula, as reflected by its color, we see the yellow and the blue considered as the small one. Usually the yellow, we see it in the neonatal care unit. The gauge for the yellow one is 24, for the blue one is 22. Once the gauge is raised, this means the caliber is smaller. Okay. The middle bore cannula is the pink and the green. The pink 20 and the green 18. These are the middle bore cannula usually seen in the obstetric department. The green one is usually used for blood transfusion because the caliber allows the passage of blood as it is a thick colloid fluid. We have the gray or the white and the orange one. These are a big sizes cannula, not seen in obstetric ward. What about the cannula insertion? As we see, we inject the vein, there will be blood here, so we pull the plunger and we push the catheter into the vein. So definitely here we will see the signs of thrombophlebitis. Let's examine this case. The cannula is a green color cannula. It is inserted in the palmar aspect of the arm. It is away from the joint. You see this is the joint, and here the catheter, it is away from the joint. The cannula is connected to IV giving set, and the patient is receiving a normal saline. Let's assume the patient is receiving normal saline. The dressing is well applied. There is no redness, no swelling by inspection, and by palpation we palpate, and we should look for the face of the patient to elicit if there is tenderness or rod-like vein. Okay, let's describe this cannula. This cannula is a green color cannula. It is inserted in the dorsum of the right hand. The cannula is in a proper side as it is away from the joint. The catheter here and the joint is here, so the cannula is away from the joint. The dressing is well applied. The cannula is connected to IV giving set, and the patient is receiving, let's say, normal saline. By inspection, there is no redness, no swelling, and we should palpate in this area over the catheter of the cannula. We feel if there is any hotness, and we should palpate here and look for the face of the patient for tenderness. And we should pass our finger horizontally like that to feel if there is cord-like vein. If any features of thrombophlebitis, this cannula should be removed and inserted in another site. What about this case? Again, a cannula that is blue in color. It is inserted in the right cubital fossa. So this is improper site. This will obscure the movement of the patient because the catheter is here. The dressing is well. The cannula is not connected to any fluid, and there is no redness, no swelling. By palpation, check for tenderness, temperature, and cord-like vein. This case, the cannula is a green color cannula. It is inserted over the left wrist, so this is improper site. The dressing is well. It is connected to IV giving set, and the patient is receiving IV fluid, and you should say what the fluid he is receiving. there is redness here and redness over the track of the vein, indicate thrombophlebitis. You should palpate for tenderness, for hotness, and cord-like vein. So this is a case of a thrombophlebitis. Okay, after general examination, let's go for abdominal examination. The abdominal examination in obstetric, we have a pregnant woman and we have another case, post-operative case. For a pregnant woman, by inspection, the contour of the abdomen for distension. Of course, I told you in the beginning of the lecture, stand on the right side of the patient, introduce yourself, ask for permission, and exposure from the nipples to the mid-thigh. These are a cornerstone in any examination, okay? So by inspection, we say that the abdomen is distended by a gravid uterus because we took history from the patient and we know that this patient is pregnant. Okay, if the abdomen wall is moved, we say that there is obvious fetal movement. Any surgical scar, we should look for finished teeth scar because it is suprapubically and not always seen. Any laparoscopy scar, gridiron incision scar, and any scar should be mentioned. Dilated veins, any skin rash or pigmentation, striae gravidarum and albicans. The patient is asked to cough or raise her head for any hernia, divarication of recti muscles. The both recti muscles will be separated in the midline. This occurs with a grand multiparous woman. Due to successive pregnancies, there will be separation of recti muscles. Abdominal wall oedema again is seen in highly parous women because of the abdominal wall. There will be oedema, what we call the pseudo orange. تشبه بالضبط قشر البرتقال. Pseudo orange because the hair follicles are fixed and the skin is elevated. Okay, so there is abdominal wall oedema seen commonly late in a pregnancy. What about the hair distribution and the umbilicals also should be mentioned. Okay, let's practice inspection on this case. The abdomen is distended by a gravid uterus. There is overt fetal movement. We assume that there is overt fetal movement. The abdomen moves with respiration. There is linea nigra. You see this is in the midline, linea nigra. The umbilicus is flat. There is striae gravidarum. This is of the current pregnancy. It is pink and broad. And here striae albicans, which is white and thin, silvery of previous pregnancies. Normal hair distribution, no dilated veins. We look for any scars here for finished teeth, incision, no abnormal scars. And we ask patient to cough and see if there is any hernia, for example, paraumbilical hernia, inguinal hernia, and divarication of recti. There will be here just like a space between the two recti muscles. Okay, this is a second case. What we see here is that the abdominal wall oedema, we see what we call it like the pseudo orange because the skin oedema will raise the skin and the hair follicle will still fixed. So this is a pseudo orange in the lower abdomen. Features of abdominal wall oedema common in late pregnancy, especially with pendulous abdomen. Okay, next by palpation. As usual, you ask the patient for any pain. If there is pain, you start away from the pain and you keep it until the end of palpation. Use right hand, examine the left lower quadrant of the abdomen and proceed to the right lower quadrant. Any palpation, you should look for the patient face because you may elicit tenderness. Palpate for masses, liver, spleen, and kidneys. These can be displaced by the gravid uterus. So, for example, appendicitis, you will see that the tenderness will be higher up because it is deviated up by the gravid uterus. Signs of peritonism, gardening, rebound tenderness, and examination of inguinal hernia and lymph node. The obstetric maneuvers in examination, first we start by the fundal height. The ulnar border of your left hand, and this is a rule, not to be changed as if you are right-handed or left-handed. No, this is a rule in obstetric. you should use your left hand by your ulnar border and mention the fundal height in weeks. For example, if we assume that the woman is pregnant 5 months period, we start higher where we expect to find the fundal height. Higher so that we will not miss a higher for gestation uterus. Okay, these points, as you see here, these are fixed points in obstetric. First, the uterus become palpable suprapubically 12 weeks gestation. Then at umbilicus 22 weeks, in between 16 weeks, here 14 weeks, here 18 weeks. Above the umbilicus, when it reaches the xiphoid process, this is 36 weeks. Between this, we divide into two areas, 28 and 32. So we have 28, 32 weeks. Okay. Before the 36, 34 weeks or 40. Why 40 comes down to this point as we see here? Because at 36 weeks, the cervix is tubular, not effaced, and the head is floating, so it reaches to the xiphoid process. With the preparation to labor, there will be shortening of the cervix or effacement and engagement of the fetal head, so the fundal head will get lowered down. So we see that 40 weeks gestation can be lower than 36. Concentrate on these numbers. It is even number, not odd number. You should not say 13, 15, okay? Only 12, 22, 36, and so on. And these are fixed by palpation. When you palpate and you found at this specific point, you mention the gestational age in weeks. Or by symphysis fundal height measurement, we use a tape measure, each 1 cm equal 1 week, and this measurement applied only when the uterus is above the umbilicus. You should not apply it below the umbilicus because it will be wrong measurement. The accuracy of this measurement is plus minus 2 to 3 weeks. For example, if we find it 28 weeks, this can be 25 or 31 weeks. Okay, here as we see, this is the tape measure. We measure the fundal height here and we specify where it is, and we measure from the fundal height until the upper border of the pubic bone. Usually we put the inches in our face and then we measure in centimeter. Each 1 cm equal 1 week gestation. The fundal grip, one of the maneuvers, this is Leopold 1 with 2 hands. Apply all your palms on the patient abdomen. You feel which part of the fetus occupying the uterine fundus. This part could be a breech, as in this case, or it is cephalic. How we differentiate a breech from cephalic? The breech is broad, soft, and irregular, and non-palpable. When we push with this hand, it will not push this hand. But the head is hard, round, and palpable. When we push from this hand, it will strike the other hand. Okay, that's how we differentiate breech from cephalic. So the aim of fundal grip to know which part occupying the uterine fundus so that we can know the presenting part. In cephalic presentation, a breech will occupy the uterine fundus, while in a breech presentation, the head will occupy the uterine fundus. If it transverse, we cannot feel any part in the fundal grip. Leopold 2 is the lateral grip with 2 hands. Fix one hand and move one hand, and fix one hand and move the other. You can know the lie of the fetus. Is it longitudinal or transverse? And you can look for the side of the back. Here it is the side of the back, usually will appear as regular part, but here the limbs will appear irregular. Here on this side we auscultate for fetal heart. Usually we hear the heart across the chest, and as you see here we will put our sonicate. So the aim from the lateral grip is to determine the lie of the fetus and the side of the back. Still we are facing towards the patient. So the first 3 Leopold, we are facing the face of the patient. Okay, By Leopold III, we apply the second pelvic grip to know which part occupying the lower uterine segment, thus to say looking for the presenting part. All your fingers over the lower uterine segment to feel is it head or breech. Leopold IV, now you change your position and you are facing the legs of the patient now with two hands. You feel if the presenting part engaged, it is passed through the pelvic brim or not. If the head is floating, like this case, your hand will be below the head. You can introduce your hand below the baby head so that your hand will be like number 7. But if the head is engaged here, you cannot be below it. Your hand will be like number 8. Okay, other information from obstetric examination. As we say, the gestational age from fundal height, presentation, the engagement, the lie. We can auscultate for fetal heart depending on the presenting part and the lie and the site of the back. You can measure the uterine contraction, so you will know the patient in labor or not. You put your palm over the uterine fundus and you count the frequency, the strength and duration of contraction in 10 minutes. You can estimate the fetal size and you can feel the fetal movements. You can determine the amount of liquor. If it is very excessive liquor, the uterus will be tense. You cannot feel the fetal parts and it will be larger for gestation uterus. But if it is oligohydramnios, the uterus will be lower than gestation and will be strictly applied to the fetal parts. The number of fetuses, whether it is single or twin. Okay, what about fetal heart auscultation? First, we determine the lie of the fetus, if it is longitudinal. Next, we look for the presentation. If it is cephalic presentation, so we will auscultate below the umbilicus. Here, the back on the right, so we put our sonicate here. Because it is longitudinal, cephalic presentation, and the back on the right. But if it is a breech and longitudinal lie, you will apply it above the umbilicus. Here or here according to the back. If the baby is transverse, you apply it at the umbilicus just above or just below. Specific notes is the occiput posterior. You will auscultate for fetal heart in the flank of the woman. Percussion usually minimal in obstetric because it is obscured by the gravid uterus. Pelvic examination for Bishop score, pelvimetry, presentation, position, membranes, and station. This is usually applied for women late, at term, or at time of labor. The abdominal examination for a post-operative case after cesarean section. The contour of the abdomen by inspection, we look for distension. We say that the abdomen is distended, and mostly post-operatively it is distended because of gases, as the bowel is not moving yet and the patient not passing motion or flatus yet. The surgical dressing, is it dry, clean dressing, or it is soaked with blood or discharge? The movement with respiration is very important. If absent, indicate peritonism. Any dilated veins, trigravidarum and albicans. Abdominal wall edema and pseudo-orange hair distribution and the umbilicus. Okay, let's practice on this case. Of course, we say the rules for examination and the exposure should be from the nipples to the mid-thigh. By inspection, the abdomen is distended and there is a surgical dressing over a lower abdominal finished heel incision for cesarean section. The dressing is clean, there is no discharge, no blood, and the dressing is well applied. The abdomen moves with respiration and there is linea nigra, there is striae gravidarum and striae albicans. The umbilicus is inverted. There is pigmentation, mostly this pigmentation like the cloisma, hyperpigmentation of a pregnancy. There is blood stained over the abdomen and there is abdominal wall edema, or what we call it the pud orange appearance. There is no dilated veins, normal hair distribution is seen. So this is by inspection. Palpation after cesarean section. The main important point in palpation is the fundal height. After cesarean, the fundal height should be felt at or just below the umbilicus, and it is firm in consistency. It should be firm. It means it is contracted. If it is soft and duffy in consistency, this means that the patient will have a bleeding or postpartum hemorrhage, atonic uterus. Then auscultation, postoperative patient, we listen for bowel sounds at the McBurney point, the junction of the lateral third and medial two-thirds of the line joining the umbilicus with anterior superior iliac spine. Here, when we apply our hands, the ulnar border of the left hand, we start higher where we expect to find the fundal height. We should start from here, okay, higher where we expect, and then we go downward, okay, slowly and gently. You should look for the face of the patient. Normally, the fundal height should be at the umbilicus or just below it, and it should be contracted, firmly contracted. If we found it above the umbilicus, this indicates delayed involution of the uterus. Then we auscultate for bowel sound, junction of the line between anterior superior iliac spine and the umbilicus, junction of lateral third with medial two-thirds. So here we auscultate for bowel sounds for a case after cesarean section. The last thing, which is a very important, is deep vein thrombosis. And here we should stand on the right side of the patient, introduce yourself, ask for permission, the exposure from the groin downward, bilateral. And first, by inspection, we inspect for the leg swelling. Unilateral leg swelling is characteristic of deep vein thrombosis. So by inspection, you say that both legs look swollen, or you say that the legs look of normal contour, or you can say there is a unilateral leg swelling that is suggestive or characteristic for deep vein thrombosis. The skin color changes, whether there is redness or pale skin, varicose veins, risk factor for deep vein thrombosis. Any ulceration occurs due to chronic ischemia. Hair distribution, is it normal or abnormal, and any over deformities, all these by inspection. Then by palpation, of course, you palpate both legs at the same time. You palpate for edema bilaterally. You palpate with the dorsum of your hand the temperature on both legs. You palpate the calf muscles, as tender and tense calf muscles suggest deep vein thrombosis. You palpate the distal pulses, the dorsal pedis artery for positive pulsation. And you can measure the leg circumference by tape measure, so that you discriminate if there is discrepancy between the circumference of two calf muscles more than 3 cm. This is suggestive of deep vein thrombosis. So here by inspection, I see there is a unilateral leg swelling. The left legs look more swollen than the right leg. There is overt skin changes. Here there is redness of the whole left leg and foot. The skin looks shiny. There is no ulceration or varicose veins, with normal hair distribution. So this is by inspection. By palpation, you palpate both legs for the edema, for any difference in temperature, and you should palpate the calf muscles, these muscles that will be tense and tender by palpation, suggestive of deep vein thrombosis. And then we can use the tape measure to measure the circumference of both legs. We take the tibial tuberosity as a landmark. We measure 10 cm below the tibial tuberosity, and we measure the circumference here, and we compare with the same point, also 10 cm from tibial tuberosity. We compare the two legs. Difference more than 3 cm indicate unilateral leg swelling, indicate deep vein thrombosis. Also, you palpate the calf muscles bilateral, and you should look for the face of the patient. Any palpation, you should look for the face of the patient. Tender and tense calf muscles, suggestive of deep vein thrombosis. This is a case of deep vein thrombosis. You see here the calf muscles are swollen, tender and tense, and there is ulceration, varicose veins, skin changes in the lower leg, suggestive of deep vein thrombosis. Thank you for the proper listening.